We'll move on to the second talk of the morning by Dr. Cohen Tanugi. Samuel.
Thank you, Dr. Pat. I am pulling up the slideshow here. I will warn you that my talk is a little bit longer than 9 minutes, so I'll try to go fast, but we may go over a little bit, so I apologize.
You have 24 minutes. You're good.
Oh, all right. So my name is Samuel Cohen Tanugi. I'm a PGY3. And my goal this morning is really to demystify the ulnar side of the wrist and provide a confident approach to diagnosing ulnar side of the wrist complaints. So the talk follows a stepwise sequence of reaching a diagnosis. We'll briefly talk about getting a good and relevant clinical history, and then we'll move into the physical exam and focus on visualizing and palpating the surface anatomy, which is really going to be the meat of my talk, and followed by select provocative maneuvers for specific diagnoses. We'll spend a bit of time looking at imaging modalities and cases before wrapping up the discussion. As you can see, I won't be talking about injury classifications or any treatment options. So by way of introduction, ulnar-sided wrist pain is often equated to the back pain of hand surgery. You'll actually see that in a lot of review papers on this topic, meaning that it's common, the symptoms are vague and confusing, and it's often frustrating for both patients and clinicians as well. And part of this is due to the fact that historically, the ulnar side of the wrist was largely ignored anatomically, earning it the reputation of a so-called black box. That term is also used frequently in reviews. And the first editions of major textbooks like Green's don't offer really any information on this part of the hand and wrist. And it wasn't until the 80s that the anatomy and biomechanics began to be studied and elucidated. Now it's well understood and we have the necessary tools to systematically reach a precise diagnosis though. So the etiologies of ulnar-sided wrist pain are commonly divided into 3 categories: acute traumatic, chronic overuse, or chronic degenerative. In generating a differential, I find simply starting with these 3 categories to be a bit limiting. I'd suggest to generate a truly broad differential, you should simply acknowledge that every tissue type here can be the source of pathology. And certainly there are patterns and some injuries are more common, and we should bear that in mind, but skin can be affected by autoimmune syndromes, any ligament can be torn, any bone or joint can have fracture, arthritis, or instability. It's really, we start very broadly so we don't miss anything. And then a good history with a few critical questions quickly narrows the differential. So, we're very familiar with these kind of classic questions. Are the symptoms acute or chronic? And it's important to realize that both acute symptoms can both be traumatic or atraumatic, which already highlights, one of the deficiencies in those 3 reported categories, which don't account for something that's acute and atraumatic. So something that's acute and atraumatic could be, for example, a gout flare or a rheumatoid flare, infection, radiculopathy, or acute neuropathy from a mass or an aneurysm, herpes zoster. Acute traumatic is a bit more obvious: fractures, ligament, or tendon tears. Mechanism-specific patterns of injury, which I'll talk about in the next slide. So for acute traumatic buzzwords, these specific activities kind of have been reported to be associated with specific diagnoses. So if a patient reports pain after a fat shot in golf, as pictured on the right, you can think of a hook of the hamate fracture, a check swing in baseball, same thing, as well as the rock climbing undercling grip, which I have a picture of on the bottom left. A backhanded tennis swing leading to a pop and immediate pain could suggest ECU pathology. Punching a wall, we've all seen this on call, often associated with 5th metacarpal fracture, and using a palm as a hammer either to drive a dowel into wood or open your beer bottle, hitting the bottle against a table, could lead to hypothenar hammer syndrome. And then in the chronic category, overuse and degenerative, I think makes sense. Chronic degenerative can actually be a form of chronic traumatic, but the patient might not really remember the antecedent trauma. But you can have arthritis, both osteo or rheumatoid or inflammatory arthritides, non-union and old fractures, ulnar impaction and TFCC degeneration would be examples as well. Other aspects of the history include the quality of the pain. This is more or less reliable, but we're generally familiar with neurogenic type symptoms. And then the literature supports distinct patterns of language used by patients with osteoarthritic versus inflammatory arthritis type pain. And then it's important to take note of the past medical history because systemic conditions can affect any of the tissues of the extremities. So gout can arise in any joint. Neurofibromatosis can affect the ulnar nerve anywhere along its course. And a patient with endocarditis, if you were consulted for a patient in the cardiac ICU with the onset of ulnar-sided wrist pain, could have emboli sent to the ulnar artery. So by this point, we should have already narrowed the differential substantially based on the patient's clinical history, and we're ready to get into the meat of the topic with the physical examination. So before delving into the nitty-gritty details, I want to step back to remind us that beyond its diagnostic value, the physical exam, especially in orthopedics, is a true ritual and an integral part of the therapeutic relationship. Famous physician and author Abraham Verghese, who's pictured here, has an excellent TED Talk. I put the link above his picture. And he describes starting his physical exam with the patient's hand almost every time. He says it's comfortable and yet intimate and carries powerful symbolism of connecting or holding hands therapeutically. Now, before you start, always ask the patient to show you the precise point of maximal pain, if possible, and save that for last. Otherwise, after pressing on that spot, everything else will probably hurt the patient and they won't be as cooperative. In the interest of time, I'll be quite brief in the bread and butter part of the exam with inspection, range of motion, motor and sensory or neurologic function. But in terms of inspection, I'll just remind you that many inflammatory arthropathies or autoimmune diseases include cutaneous or nail manifestations that you can take note of. And chronic or severe degenerations of ligaments can lead to altered morphology with, for example, a volar sag of the carpus with a chronic LT tear. Sorry. The most important of this talk is understanding the surface anatomy of the wrist. The goal here is to be able to visualize the underlying structures like in this tattoo. I didn't find an equivalent tattoo of the wrist, which would have been cool. But luckily, even in the majority of overweight patients, it's still possible to reliably palpate the relevant structures, which I'll go over. And one simple way to practice visualizing the anatomy is to draw the outline of your hand and wrist on a sheet of paper and then fill in the structures and try to do so by memory. I'll show an example of that on the next slide. So here's some great drawings of the important structures we'll cover by Dr. Gaston and a previous resident, Dr. Elliot Robinson. As I walk through a full circuit of the surface anatomy, you're encouraged to palpate your own wrist. If we were doing this live in person, I would actually have everybody hold up their hand. So start by identifying the pisiform labeled P on the drawing on the left. It's a bony prominence here, immediately distal of the wrist flexion crease ulnarly. And the FCU tendon inserts onto the pisiform and is easily palpated, moving proximally along the ulnar volar wrist or flexing your wrist. Next, if you place your thumb IP joint directly over the pisiform, aiming towards the ring finger, the tip of your thumb will naturally land over the hook of the hamate, which will feel like a more subtle bony prominence. The ulnar head is immediately visible and palpable in the ulnar dorsal quadrant of the wrist, and the ulnar styloid is the most dorsal and distal aspect of the ulnar head. If you start on the ulnar styloid with your examining finger or nail, you just let your nail slide volarly into the groove adjacent to it, and this is what we call the foveal point, which houses the TFCC. The ECU tendon, which lives in its own subsheath, basically overlies the dorsal ulna. Now we're going to move to the dorsum of the wrist. If you palpate Lister's tubercle, which is a classic landmark for most of wrist anatomy, and you move ulnarly along the distal radius until you just kind of, I like to use my nail for this because it's kind of sensitive, but you fall off a sort of an edge, which is the edge of the radius, and you're in the DRUJ. So you can feel the DRUJ there. And then if you move about 1 centimeter directly distal, you'll fall into a subtle groove. And that's the LT interval, and it feels very similar to the scapholunate interval, which would be 1 centimeter distal to the Lister's tubercle. And then starting at the 5th metacarpal shaft dorsally, you can palpate your way down to the 5th CMC joint. And then proximal to that is the dorsum of the hamate, which can be fractured. And radial to the 5th CMC joint would be obviously the 4th CMC joint. So identifying specific areas of point tenderness with the underlying anatomy in mind can be both sensitive and specific for particular diagnoses. Most classically, foveal tenderness, which is that point just distal and volar to the ulnar styloid, has been shown to be quite specific and sensitive for TFCC injuries. Now that we have a good history and we know our point of maximal tenderness, we can use provocative maneuvers to confirm a suspected diagnosis. So these maneuvers are not to be used as indiscriminate screening tools. Not every patient gets a full battery of the ones listed here, but they really should be used to confirm a diagnosis. I'll quickly cover all of these. I'll go pretty fast. They've been described in the literature, although there isn't always good data associated with supporting them. I'll start with the Ulnocarpal stress test, which was described by Nakamura and colleagues. It's very sensitive for ulnar-sided wrist pathology, so essentially everything I'm talking about, but it's not specific for any particular one. It's performed by placing axial pressure on the wrist in ulnar deviation and passively ranging in pronation and supination. And in their study, basically 100% of patients with a positive test ended up having ulnar-sided wrist pathology as documented by MRI or arthroscopy. The hook of the hamate pull test was described for hook of hamate fractures. It consists of flexion of the fourth and fifth against resistance with the hand in ulnar deviation. So you resist that, and then if you bring the hand back into radial deviation, that should alleviate the pain that the patient feels. And in very, very small series of 4 and 5 patients respectively, for a total of 9 patients, every patient with a positive test ended up having a hook of hamate fracture with the obviously with the appropriate history for it. For LT tears, several tests have been proposed to assess Luno-Triquetral tears. Kleinman, who wrote a classic paper on this, describes a shear test, which is also named the Kleinman shear test, which he says is more controlled and specific than the Shuck or ballotment test previously described by colleagues. The test is performed by squeezing the lunate dorsally, as you can see in that picture, and then the pisiform volarly. So you, between your 2 thumbs, and that allows for kind of a controlled incremental pressure delivery to that system. And because the energy is transferred to the PT joint volarly, you have to make sure the patient doesn't have PT arthritis, which is actually not uncommon for older patients. And you can do that by using the PT grind test or tracking test for PT arthritis. So with the wrist in slight flexion, you can actually pinch the pisiform between your index and thumb and put a little bit of pressure dorsally, and then just shuck it back and forth. And that would be painful in a patient with arthritis. To test for DRUJ arthritis, you can simply stabilize the hand and then squeeze the DRUJ just distal to the ulnar styloid and radius, and that should be painful in DRUJ arthritis. As opposed to DRUJ instability, which can exist with or without arthritis, the described piano key or ballotment test is sort of self-evident. You stabilize the radius and then try to shuck the ulna relative to the radius within the sigmoid notch back and forth, or dorsal to palmar. The ECU Synergy Test is described by Roland and colleagues and was found to be both specific and sensitive. They basically correlated negative MRIs for ECU pathology with patients with a negative test. And then for positive tests, patient had temporary resolution of symptoms, sometimes actually long-term resolution of symptoms, with an anesthetic injection into the ECU subsheath specifically. Finally, I'll wrap up this section with testing the triangular fibrocartilage. Although I don't have time to fully delve into the anatomy and biomechanics of the TFC, which could be a talk in and of itself, I at least need to provide a quick refresher, because the provocative maneuver is just a direct application of the biomechanics. So these are all pictures from Kleinman's classic paper on the TFC. So I'll remind you that the critical fibers of the TFC for stabilizing the DRUJ through its arc of motion are the deep fibers here depicted in blue. And these drawings from Kleinman's paper depict how the volar or the dorsal fibers are tight, respectively, or loose in supination and pronation. So on the left image, in supination, the ulnar is shifted naturally volarly within the sigmoid notch, because they don't have equal radii of curvatures, and therefore the deep fibers the dorsal deep fibers are tight, and vice versa in pronation on the right image, which is actually flipped. You can look at Lister's tubercle, will tell you what is dorsal. So to test this, when examining the patient, you're simply trying to push the ulna past its extreme position in the sigmoid notch. Now, in supination, you're pushing the ulnar away from you or volarly. And a great mnemonic to remember both which fibers are naturally tight in which position and which fibers you're therefore testing is that just remember that you're sitting across from the patient. And so when the patient is supinated, you're looking at the dorsum of their hand. And so therefore you're testing the dorsal fibers. So whatever you're looking at, that's what you're testing. Vice versa in pronation, you're looking at the palmar surface and you're testing the palmar fibers. Finally, I already mentioned the possibility of injecting a specific area when for differential injections when talking about the ECU subsheath in Ruland's paper. And this can be done for any number of other areas, including the TFCC into the foveal area or a specific carpal or CMC joint. And this can aid if you're still having some ambiguity between a couple diagnoses. A great example would be, for example, the ECU subsheath would be considered an extra-articular diagnosis versus TFCC would be an intra-articular. And so that's kind of what Ruland and colleagues did in their paper. By injecting the ECU subsheath, you're still extra-articular. And so a patient with TFCC tear should not have their symptoms alleviated by an ECU subsheath injections. Injections into joints can be done under mini C-arm or with the use of ultrasound. And it's getting more widespread use both as a dynamic imaging modality for ECU subluxation, for example, or for injections. And I'll note that it can be billed separately. And so I think this is one incentive to start using this. We're not really trained in using ultrasound, but I think it'll probably gain more widespread use. And so that will be a good segue into the last section of this talk, which will be imaging. So here's an example of ultrasound. We're not used to looking at ultrasound, so I'll kind of walk us through this to evaluate the ECU tendon. What we're seeing here is an axial view of the ECU tendon in supination and pronation. The yellow arrow is a cross-section of the ECU tendon in its subsheath. And then the ulnar groove is depicted by the gray arrow, which is a poor choice of color, I think, for this. So I apologize. But what you can see is in full supination, the ECU is clearly more subluxated than in pronation, although it's kind of slipping out of its groove in pronation as well. So every patient who presents for wrist pain in an office gets at least a PA and lateral X-ray of the wrist. When evaluating the relationship between the distal radius and ulna, the position of the patient is critical. For a true PA, the arm should be abducted at the shoulder and the elbow at 90 and the wrist in neutral. In the next slide, I'll show an additional view that can help demonstrate ulnar positive variance. On this lateral, you can see a subtle dorsal triquetral fracture, which you can imagine would easily be missed by anybody who's not an orthopedic doctor, but even by a non-specialist. These are actually quite common. So in this series of x-rays, a wrist that appears relatively ulnar neutral on a PA then shows positive ulnar variance with a pronated grip view, where the patient is gripping something and pronating, and you can see several millimeters of ulnar positivity there, suggesting maybe a dynamic ulnar impaction. There are a variety of other positions that can be used on x-ray to better assess individual bones or joints. Probably the most common one is the carpal tunnel view, which is a sort of an axial x-ray that can show a hook of a hamate fracture, or in this bottom picture, a pisiform fracture, which would have definitely been opaque or occult on a PA. Here's another example of using a specific position to optimize the visualization of a particular bone and joint. In this case, the pisiform and Pisiform-Triquetrum joint. You could kind of do this for any bone or joint in the hand, since you can move the hand in any position, so it's kind of nice. CT scans are much less common. They do have a few defined advantages. They provide the best bony detail, arguably, so are used to evaluate for trauma, as well as assess healing of fractures over time if there's concern for a non-union, for instance. Whereas an MRI, would probably show some edema and inflammatory changes for a number of months after a fracture. Doesn't really tell you much, but a CT scan can help you assess union. They can also be done very quickly. Certain clinics or office settings have their own CT scanner in the office that you can just get as if you were, same way you were getting an x-ray for distal extremities. This image here demonstrates a hook of the hamate fracture that was occult on x-rays. Perhaps the greatest advantage of the CT scan is that it can be used as a dynamic study. Essentially, the ease and speed of obtaining the images allows us to obtain the same CT with the wrist in different positions, or compared to contralateral side. So the next slide here, this set of images, like a lot of the ones that are to follow, are courtesy of Dr. Robert Lopez of MSK Radiology, who helped me get some of these images. So here, a CT scan of this patient was obtained, both the symptomatic and asymptomatic wrist, and at the extremes of pronation and supination within the scanner. So basically, you got 4 CT scans to assess for DRUJ instability. In the top image, you can see that the left DRUJ is unstable in pronation, with the distal ulna extending more dorsally than the contralateral side. And this instability is not seen in supination, which suggests a tear in the deep volar fibers of the TFC. MRI and MR arthrogram are certainly the most common modality of advanced imaging, especially in the, as the technology has continued to improve. Now we have dedicated wrist coils, as depicted in the bottom image, and more powerful magnets. I think Atrium Health just got its first 3 Tesla magnets, like in 2020. The standard used to be 1.5 Tesla. The vast majority of patients with ulnar-sided wrist pain will get an MRI. In the top picture, the patient is in a 1.5 Tesla magnet MRI, which doesn't necessarily have a dedicated wrist coil, and the patient is in the Superman position, which obviously places their wrist in pronation, which arguably is not ideal to be forced in that position. Newer MRIs with more powerful magnets and the dedicated wrist coils allow for neutral patient wrist positioning, like in the image below. To obtain an MR arthrogram, the dye is injected into the radiocarpal joint, like you can see here, at the level of the scaphoid fossa. And here we're just looking for leaking of dye into other areas, such as the midcarpal row or the DRUJ, which would suggest ligamentous tears or defects. So it's important for MRIs to bear in mind that, like in other parts of the body, such as the spine, we don't always know what to do with better imaging and MR findings. Studies have shown a high rate of incidental findings. One study found 39% of TFCC abnormalities in asymptomatic patients. Another study found a very low positive predictive value of 6% for ECU abnormality when they retrospectively reviewed a large number of MRIs of wrists for any number of complaints, for patients who, for example, didn't have an ECU tendon pathology but still had ECU anomalies. And finally, patients with ulnar-sided wrist pain may have multiple coexisting pathologies. So in this picture, for example, this is a patient who actually had a TFCC tear, which was symptomatic and was repaired. But the MRI also shows this ECU tendon longitudinal tear, which is small and is probably irrelevant. Should we do anything about it? Finally, I'd like to demonstrate what some of the pathologies look like on MR and give some examples of how beautiful the resolution can be on some of these images. Here's a subluxated ECU creeping out of its groove in the ulna. And the ECU pathology is best looked at on axial cuts. This is a 3 Tesla MRI. The TFCC is generally assessed in the coronal plane. On the left, a normal TFCC, what you can see is really kind of these fibers here that originate on the distal radius and insert both superficially over the styloid and into the foveal point here. And you see a nice outline of the cartilage. And on the right, you can see there's an MRA extravasation of contrast into the DRUJ, suggesting a small tear or a defect. Here's the same case with different sequences to kind of highlight the way that it looks. Here on the right image, you see again a more radial-sided TFC tear with some extravasation of contrast, and on the left, some associated marrow changes suggestive of early chondromalacia in the lunate. On the left is the same picture of earlier with the arthrogram, and this is just basically an X-ray to confirm that the arthrogram is working, but you can already see some dye leaking from the radiocarpal joint through the LT joint into the carpal row, and that would pretty much be diagnostic for an LT tear. And on the right side, here's an MRI, high resolution, and it's also an LT tear. And that's basically seen by the fact that you have a really nice contour of the lunate and the triquetrum without any fibers between them, which is where the LT ligament should be. You can compare that to the scapholunate ligament, where you can kind of see these hazy longitudinal or horizontal fibers. That's what you would expect to see if you had an LT ligament. So how do we get these high-res MRIs? We've all seen some MRIs that don't look that good. So there are 3 there's some 3 Tesla MRIs at CMC Maine, Atrium Health Northeast, and Atrium Health Pineville. These are inpatient hospital MRIs, so they're more expensive. There's also an outpatient one at South Park, and that's cheaper because it's not billed as a hospital MRI. It's my understanding that Ortho Carolina doesn't currently have a 3 Tesla MRI. So in summary, here are my take-home points. The ulnar side of the wrist is not a black box. We understand the anatomy and the biomechanics make sense. Clinical evaluation is a puzzle. It should not be a headache, but should be kind of fun to diagnose, knowing that you know that all the pieces are there. And the key is to just know the anatomy, be able to visualize it in your mind's eye, and learn to palpate it. Finally, for imaging, positioning is critical for the x-rays, and MRI is the most common advanced imaging and nowadays can provide absolutely great resolution, but we should be aware of incidental findings and we'll always need to correlate findings to our H&P to make sense of the images. So here are my references, and I'd like to thank Drs. Gaston, Gant, and Ward of OC for their help with this talk, as well as Dr. Lopez of MSK Radiology for providing some great cases and images. Happy to take any questions.
Thanks, Samuel. Nice comprehensive review of the ulnar side of the wrist. Couple of a quick comment followed by a question for you. Comment is about the 3 Tesla scanner. So we actually have had at Moorhead Medical Plaza a 3T scanner for almost 5 years now. So that's been here for a little while. It is really good for looking at smaller joints. It's excellent for hand and foot. Certainly very useful for that. One limitation of it that people should know about is that it is useless when you have hardware in place. The scatter and backscatter from metal hardware with the 3 Tesla magnet is really bad. So if you have anybody with existing hardware, you definitely want to make sure you order it on the 1.5 Tesla magnet. So there is one here at Moorhead Medical Plaza. It's possible that that's billed as a hospital facility, but I thought that it was an outpatient facility. So I think that that's helpful to sort of understand when you can use it. The question I had, just a few years ago, when I was a resident, I did a talk on scapholunate injuries. And at that time, a lot of the literature was pointing to the fact that wrist arthroscopy was actually maybe the gold standard for evaluation of ligamentous injury in the wrist as opposed to MRI. Did you find anything about that? Has the institution of a 3 Tesla magnet, made that data irrelevant, or is that still something that some of the hand folks believe?
I would still say that arthroscopy largely has that role of being the gold standard, with the exception, and Kleinman's article really outlines this well. You can't really see the deep fibers of the TFC because they're under the superficial fibers of the TFC through the normal portals into the wrist. And so you really need your physical exam and the MRI to accurately diagnose a tear in the deep fibers of the TFC. You won't be able to see them, at least from the standard portals. They may be fancier portals that I don't know about that somebody else can comment on. For the most part, the arthroscopy kind of allows you, it's more dynamic. You can actually move the wrist as you're observing it, and you can kind of poke around and see whether a tear or a defect is actually associated with instability. So I would say for the most part, it's still the gold standard, but I do want to point out that there's some pathologies that you might not be able to see by arthroscopy.
Yes, Glenn, Samuel, I agree. Great talk. Just good overview of ulnar sided wrist pathology and getting a good exam. And I agree with you. The gold standard, Josh, to your point, I think that's very true. Arthroscopy still would be, for the majority of wrist pathology, considered, quote, the gold standard. But a lot of times it's not going to change our treatment early on. So we use MRI to help us decide where should I inject and things along those lines while we're in the conservative treatment realm. The other thing I was going to point out, I think it was a good thing you added with the ultrasound. I do think ultrasound is going to really help, particularly with like ECU pathology from a diagnostic standpoint. You mentioned it can be billed for with injections. I'll just throw out my personal bias. I personally think for a lot of wrist pathology, trigger fingers, de Quervain veins, ECU, I think any physician should really be able to do those injections without ultrasound guided because it's so palpable beneath the skin. So I think charging patients, I've seen plenty of patients who come in for another opinion and they've had ultrasound guided trigger finger injections and de Quervain veins injections. And I really think that's just contributing to an increased cost that's really unfair for the patient to have to bear when it's an injection that should be able to be done. I think when you get into specialized ones like STT injections or very small joint injections, I think that's very fair. And I think it's fair to bill for it from a diagnostic standpoint. But I think some of the injections that are done are kind of stretching the limits, at least in my opinion, of what should be billed for.